And then next up, lastly, for today, we have Anthony Lledo presenting a fatal MRSA meningitis from Calvarial Osteomyelitis following chemical burn, a case report. So, Anthony, if you just want to share your screen and we'll be all ready to go.
Well, hi everyone. I'm Dr. Anthony Lledo. I'm a second year resident at New Hanover Regional Medical Center in Wilmington, North Carolina. Today I'll present a case that I came into when I was doing my infectious disease rotation. So just a brief introduction, MRSA, uh, meningitis accounts for 1 to 5% of bacterial meningitis, roughly. And mostly all the cases are seen post neurosurgery or in the hospital setting. That being said, this case raised curiosity among every provider that was working on it. So this 43-year-old patient presented with women, female, presented with 3 week history of purulent discharge in the right side of her temple, in the right temple, but worsening imbalance and knuckle rigidity, confusion, and headaches. Um, Her past medical history was significant for IVDR abuse, chronic hepatitis C, and high blood pressure. So, as I said, she had this purulent discharge for 3 weeks. And but everything started on history taking. We learned that everything started roughly 7 months prior to that presentation, wherein when she was bleaching her hair with bleach, of course. She developed a chemical burn. She started having pain and itchiness, but never seek medical attention. So it wasn't until she started developing worse symptoms like the ones that I mentioned, the imbalance, the knuckle rigidity, and the confusion, that she seek medical attention. And what we noticed was that she had signs and symptoms of meningitis. So the emergency department started antibiotics or empiric antibiotics for meningitis, CSF, and was remarkable or evident for bacterial meningitis. And on imaging, as you can see, they were able to see the lytic lesions or soft tissue thickening in the right parietal region, and the bony destruction of the of with the cranial osteomyelitis, and that's when they called the ID department. So the culture of the CSF grew MRSA. That made us tailored the antibiotic regimen, and we added linezolid to the medication therapy. Um, Unfortunately, 36 hours into the admission, the patient had a PEA arrest and passed. Um, the pa- we never got to figure out why she developed that PERS, but part of the workup in the ED was an echocardiogram that revealed that she had heart failure with reduced ejection fraction. Um, and that basically put her at risk. We thought that it was because of stress, uh, cardiomyopathy, or probably septic cardiomyopathy, but um, blood cultures were negative. So everything pointed out to stress. So this is, I mean, because of the how rare MRSA meningitis are as a whole, and as in this case, someone that developed this infection from a chemical burn and not something that happened in the hospital. That's basically the value of the case, and how to uh, diagnose or the work that we need to do in management for chemical burns that and on bacterial meningitis like this case. Um, I'm looking to any questions if there's any at this moment.
That's very cool. Thank you, Dr. Lledo. One question I have, so you mentioned that her scalp wound was very chronic, like 6, 7 months. Was there any tells in just the physical exam of the wound, like right before she acutely worsened?
So, because of her confusion, part of the medical history was provided by her significant other at bedside. And he was telling me that the first signs that he saw was like redness, itchiness, but that tend to like or develop through the days, months, and became purulent. By the time of presentation in the emergency department, mostly all of the wound was covered by a black escort with some purulent discharge in the border of the escort. So we never got to see or we never did like debris mend or anything that could allow us to see the extent of the injury. Unfortunately, because of what happened to her with the PEA arrest, we never got to pursue that workup.
And then it looks like somebody asked in the chat, based on the case, would you suggest any changes to clinical protocols for managing scalp burns complicated by infection?
So one of the things that I was talking to my attending back then was that she was started on, for example, ampicillin, right? And that's a medication that physicians or providers in the ED need to assess meningitis or bacterial meningitis for a broader or higher point of view and see what is bringing the patient to the ED. In her case, it was bacterial meningitis, but there was an obvious scalp wound and the imaging too. So they thought that this was like listeria meningitis, for example, and she was being treated only with that, right? And so a good history taking and clinical knowledge and expertise to be able to identify that this is not a regular meningitis, but MRSA or not immediately MRSA meningitis, but something that is because of her chronic wound, definitely.
All right. Well, thank you so much, Dr. Lledo. Really interesting presentation.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.